Well, welcome. Good evening, everybody. At least it's evening where I am in Western Canada. I just want to welcome everybody to this very first VR Professor Series put on by Precision OS, and I'm very proud to help chair this meeting. And a big welcome to everyone from around the world. We have people registered from, I think, almost all the continents, so that's really great to see everybody. So how we're going to go forward this evening, we have a really great cast of faculty here, and I'd like to introduce them to you. But first, I'd just like to thank Precision OS. They've been putting out really great virtual reality modules, and especially with sport medicine and arthroscopy, working with ConMed, who's sponsoring tonight's meeting. So thank you to our sponsors for putting this on for us. And our great faculty and our first visiting professor is none other than Dr. Al Getgood. And Al is an orthopedic surgeon. He does knee, sport medicine, and arthroscopy in London, Ontario, the lesser known London, perhaps. And Al's a very good friend of mine and even has done some training here in Banff, although some may argue who taught who more while he was in Banff, but we'll see how we go today. Anyway, Al is our visiting professor and will be helping us out in the VR to show us around. Along with Al is Dr. Danny Goel, and I've known Danny for a long time also as we've worked together through our training in Canada. He's an orthopedic surgeon, although he veers a little towards shoulders. He actually does a mean ACL in the VR, I can attest to. He works at UBC in Vancouver, and he is also the CEO of Precision OS, so this is his vision. And then helping us along today, we have two residents, Marcelo Teixeira. He is from Brazil, and he is an orthopedic surgeon and hand and wrist resident, and he is very passionate about VR. And he's going to help us in the VR room. And Liana Tedesco, who's a chief resident in New York Presbyterian, and she's gonna actually stay on the Zoom and take care of you good folk who are on the Zoom. We're going to start with a little 10-minute presentation by Al going over the VR and what it has to offer. And then the four of us are going to break out into the VR room and get ready while Liana gives you a talk, and she's going to take care of you on the Zoom, and you'll be able to watch what's broadcast from the VR simulation. So welcome everybody. Thank you so much for being with us, and I'm going to hand it over to Al for his presentation.
Perfect. Thanks very much, Laurie. Thanks very much for the introduction. And of course, I'll just reiterate, thanks very much to Precision and ConMed for sponsoring as well. It's great that we're getting this going. So I'm just going to share my slides. Hope you can see this. There we go. Okay. So what I thought I would do is really just focus a little bit on ACL reconstruction, and recognizing that there's already a broad range of experience of people on the call. I thought I'd keep it fairly basic. And really as a sort of as a way of an introductory, and then we'll get into the VR room, and then we can really show what VR has to offer by actually being in VR and doing an ACL reconstruction. So I do have some disclosures. I'm on the advisory board for Precision. My practice profile, I am in academic practice, and as Laurie said, I am in maybe the lesser known London, Ontario, but it still looks after us very well for sure. So I've been there for about 10 years. And I only do knee surgery, so soft tissue knee surgery, of which ACL reconstruction comprises a large part of that. So I do about 150 ACL surgeries per year, the majority of which are primaries, but I do some revisions, and the majority are in younger population, of which some are competitive and recreational athletes. So the overview, really, what I wanted to do was think about who needs surgery, why we do it, how we do it, what are our expected outcomes, and then we can talk a little bit about complications. And then we're really going to get into VR and see how VR can really help us in terms of actually mastering our techniques. So here's a typical ACL injury. So it's a young girl playing volleyball. You'll see that she's going to go up for a spike in a second. And when she lands awkwardly. Her foot is outside her center of mass. Knee gives out. She drops into a valgus collapse, and her knee gives out. So now this video is a little bit more detailed. You can see this is actually a soccer player who's playing for England a number of years in the World Cup, and you can see the knee basically subluxate and then reduce. So his ACL was torn and then it reduced into place. This is just a very simple animation of what the ACL is. So it's a structure that sits in the center of the knee, and it controls anterior translation as well as anterolateral subluxation. So what, in terms of when we think about ACL injury and reconstruction, well, about isolated ACL injuries account for about half of all knee ligament injuries. 70% of the injuries occur during sports activities. It's the most common knee ligament injury that requires surgery. The most common ligament injury is MCL, but the ACL is the most commonly one that's operated on. It mostly affects the young active population. It's a very common procedure. Some of the industry numbers would suggest maybe 200,000 procedures are performed in the USA per year. Fowler Kennedy, we're doing about 450 to 500 per year between all of the surgeons here. Now, we often think that we have high rates of satisfaction with our patients, and by and large, that's fairly true, and high rates of return to sport. We often think that that's the reason for going back to or doing the surgery in the first place. But it's not perfect. The surgery certainly is not perfect. We actually look at some systematic reviews. If you take all comers across multiple studies in a systematic review, you're looking at approximately a 60% return to sport. Unfortunately, there's a high rate of failure in young active patients that, depending on the study and depending on the patient population, that can be anything up to 20% failure rates up to 2 years. Rotational stability can continue to be a bit of an issue, as seen when we do an examination looking at the pivot shift. And unfortunately, we have a large incidence of the development of post-traumatic osteoarthritis, which is often very focused, very dependent on meniscus status. So it's not a perfect operation, and that's why we look to these different techniques to see if we can optimize our techniques and improve our patient outcomes. This would be a common scenario that I would see: a 17-year-old female soccer player. She has an acute non-contact plantar and pivot injury when playing, feels a pop, the knee becomes swollen. She wants an ACL reconstruction and is planning to return to competitive soccer. And that's the conversation that we're going to have in the office. And it's often with her and also with her parents. And these can be quite interesting conversations at times. After a full history, and then we're going to get into an examination. And here we're looking for evidence of anterior laxity, as you can see here with the Lachman test. We will look at for any evidence of any collateral ligament injury. And then we're looking at some rotatory laxity. So lots of different clinical tests that we look at to try and determine the extent of the knee injury that we're dealing with. And then lastly, we're going to be doing pivot shift examination. She's got a really quite significant rotatory laxity in this right knee. If we do radiographs, we can see that she has pretty normal bony anatomy, apart from the fact that she has an increased posterior tibial slope, as marked out with those red lines. That puts her actually at a higher risk of re-injury. So these are some of the conversations and things I need to point out to this young girl. Now, an MRI scan, this would be typically done around the world. Sometimes we don't get MRI scans, depending on the acuity or how quickly the patient wants surgery. But essentially, in this instance, this MRI showed really quite significant bone bruising in the lateral compartment of the knee. This has been shown to progress over time to develop cartilage injury, so this can be a problem. We see lots of soft tissue injury on the lateral side of the knee. This is what we call an anterolateral complex injury. And also, we see the lateral meniscus has a posterior root tear, which may also be a concern regarding her meniscal function and even failure later on. So what can we do? Well, we can certainly do a root repair. This is a lateral meniscus root repair. We can drill tunnels. This is not her knee, but as the tunnels are in a slightly different position. But essentially, we can drill anatomic tunnels in the femur and the tibia to be able to reconstruct the ACL. We could use an appropriate graft. In this instance, this is a hamstring tendon. And it looks like when it sits in the center of the notch, and this is what we're going to be doing in the VR module. So this is a good idea just to have a look at this. And then we can also add something called the lateral extra-articular tenodesis. This is not in the VR module, but something that's becoming somewhat popular in young active individuals. And this is where, the academic side of our practice really focuses on, because we have been involved in multiple randomized clinical trials. This one in particular, focusing on the addition of lateral tenodesis to ACL reconstruction, showing that we can improve our failure rates with this extra procedure. And this, then the second study, Stability 2, we're currently doing at the moment, which looks at different graft options, looking at the patella tendon or the quadriceps tendon. And so when we actually look at graft selection, if I look at my practice as things stand, because of Stability 2 trial, the majority of my patients I'm treating either with a patella tendon or a quadricep tendon through that randomized trial, and then a smaller population with hamstring tendons. They're all basically, the majority of patients get an autograft, in other words, tissue from their own knee. A very small proportion of patients will require an allograft, a donor tendon. all tendons are soaked in a vancomycin soaked sponge prior to implanting the graft into the knee, in a way of trying to reduce infection, which I'm going to talk about in a second. So in terms of our positioning, this is what it looks like in the OR. I use 2 foot rolls. So again, I can change the position of the leg very easily. We'll mark out our skin incisions and our portals. We can talk about that in the VR module in terms of where we put these portals, because there's lots of different options depending on the different techniques that you're utilizing. In this example, we're using an accessory anteromedial portal femoral tunnel drilling technique. And this is what it looks like on the scope. So essentially, we're looking through the high anteromedial portal, and we can see this is the ACL footprint. And then the ACL, there's a number of proprietary guides that are available that really help us determine where the position is. We then pass a pin and then over drill that pin with a smaller drill. This is what's called a 4.5 millimeter drill. And then we can drill that up to a larger socket that's going to take our graft. And so that's going to be our femoral tunnel preparation. Okay, next up, we're going to do, and this is what it looks in real time. So this would be my setup in my OR. You can see the patient lying. I'm just to the side of the patient, and then the arthroscopic image right in front of me. And so very, very straightforward with the anesthesia and everything at the head end. In terms of the tibial tunnels, well, we're using this special aimer. You're going to see this in the VR module, how we actually set that up. We pass a pin, and then we over drill that again with an appropriately sized drill. This is what it looks like. In reality, you can see on the TV screen there, you can see the drill coming up through the tibial footprint, which then creates the tibial tunnel. So I've now got a femoral tunnel and a tibial tunnel. In terms of our graft fixation, lots of different options. We can use different things like what we call suspensory loops. We can use screws that creates an interference screw fixation into the tibial and femoral tunnels. And then we can use staples or other anchors for the lateral tenodesis. So lots of different graft fixation options that are available to us that are provided by our industry partners. These are my current indications for the inclusion of a lateral tenodesis. Certainly in the majority of revisions, I'll use an LET. In the primary scenario, young active patients who wants a hamstring tendon graft for some reason, I'm much more commonly using either a patella tendon or a quadricep tendon graft, which I mentioned. And these would be some of the indications that I would use, but it's probably outside the scope of this particular talk. Often the ACL surgery is the more routine bit. The more difficult things that we have to do, we have to address are the meniscal tears. And about 80% of cases often have a meniscal injury. That's probably illustrative by the fact that a lot of our patients are coming a little bit more chronically than acute injuries. And 75% of those will hopefully get a repair. And again, there are a number of different options for repair in terms of the instrumentation that we can use. Unfortunately, 25% may well require a meniscectomy, which can be a problem later down the track in terms of the development of post-traumatic OA. Complications that, if there are any residents on the call tonight, which I hope there are, things that we got to talk to our patients about. There is a risk of infection with any surgery. Since the advent of the use of vancomycin soaking grafts, actually our infection rates have really reduced quite significantly. Which is to my mind, is a major breakthrough in the last 10 years of ACL surgery. Deep vein thrombosis, certainly an issue, less than 1%. These are young, healthy patients by and large, and we get them going pretty quickly. Loss of motion can be an issue, but this really depends on the amount of surgery that we do. Traumatic graft failure, depending on the type of graft, depending whether you added LET changes. And certainly it would be interesting to see what stability 2 shows when we look at the patella tendon or quadricep tendon with lateral tenodesis as to whether or not we can really reduce our failure rates even further. But certainly persistent rotatory laxity may also be an issue. Our rehabilitation, we tend to try and get our patients' weight bearing is tolerated, and certainly the meniscus status often drives our restrictions. So the meniscus, if we have a significant repair, such as a root repair, we may go a little bit more slowly. There are a number of criteria that we'll use that will base our progression in terms of when they can go to the next level to progress on with their rehab. And then in terms of return to full activities, there are a number of different functional outcomes that you can use, whether looking at neuromuscular functional outcomes, strength indices, time criteria. Certainly time is an issue, and the majority of my patients would not be returning to contact sports for at least 9 months post-op, but most likely closer to a year. And then obviously and this has been a lot of research into this in terms of psychosocial aspects. There's a lot of fear avoidance, a lot of concerns about going back to sport, and that often has an impact on their ability to return to sport. The actual numbers that do return to sport, well, it's very dependent on their age and activity level, and certainly in the stability study, 82% went back to return to sport. The older, as patients get a little bit older, life gets in the way, whether it's having family, changing the type of sport that they want, those numbers certainly drop off. And those are conversations that we have with those individuals at the time of their injury and then ongoing through their rehabilitation. So with that, I'm going to shut it down there. That hopefully gives you a bit of a little teaser for what's now to come, and hopefully we'll get into the VR room and that we can go through a reconstruction live in VR.
Thank you, Dr. Getgood. That was a great primer on ACLs. I'm going to share my screen. I have a few slides. Again, my name is Liana Tedesco. I am one of the chief residents at Columbia in New York City. I'm going into hand and upper extremity fellowship this summer. And I just wanted to tell you a little bit about my experience as a resident using VR and precision specifically. So I first started using VR when I was a PGY2. I was introduced to Precision OS during March 2020, when I think many people remember the surgical volume had really decreased, particularly in New York City. So using VR, especially as a 2, when I was still learning a lot about being an orthopedic surgeon, was a great opportunity to start seeing cases from beginning to end before I went to the operating room. So I felt much more prepared. We utilized it a lot in our education during that time to sort of fill in some blanks that we may have been missing. We were really only doing trauma cases because that was what was, elective cases were not being done. As I got more senior, the VR platform has become much more helpful for other skills that I've had. So I, felt like as a PGY2, obviously I was not often doing cases start to finish, but in VR, I was like, I got to be the surgeon from the beginning to the end, which I thought was a really great mental place to set in and give me a better idea of what it meant to really be the surgeon. Now I use it more in terms of fine-tuning techniques and as an educational tool. I was able to play with angles as it came to drilling, see if I'm in a skiffy case or I'm doing the preparing the glenoid for a shoulder arthroplasty. If I was going to anterior to posterior, perhaps just putting the pin in the wrong plane, and I was able to use these modules to see what mistakes I was making, so that I didn't have to make them in the OR. I could make them in a safer environment, and I think this has really helped me hone my skills, so I don't make those mistakes anymore. And I think as an educator, something that I'm really passionate about, particularly when I'm teaching medical students and junior residents, Precision OS has provided a great platform to review operative pathology in cases in a 3D environment. So I can go through things with junior residents, either they can have the headset or we can be in VR together, which is really, really quite wonderful. This has been a great opportunity for me to teach, as well as, learn myself. It's helped me hone my teaching skills in addition to my surgical skills. So I think some of the benefits of being able to, pull the bones out of the body, take a look at where you're putting the plane. I always kind of come back to the Skiffy module. That was the first one where I really felt like I was able to make a difference in my surgical technique, because I was seeing kind of in 3D what these slips look like and what kind of angles you had to get, and how that changed based on how extreme the slip angle was, or as a 2, going through hip fractures, going through all the steps and knowing second nature, this is how to do this part of the surgery. Now, when I go in, it's not about what's next. It's how do I make this, go smoothly, efficiently, and get appropriate reduction, things like that. I think VR, as far as I will be using it as I go forward, is really the future of surgical education. We've shown with data that it can really improve the number of clinical errors. It's more cost effective than using cadavers. It's not meant to replace the surgical tools we already have, but be in addition to the surgical toolbox, is particularly for resident training and even for attendings as they go out into practice, being able to use new techniques, new implants, new technology to improve the general education of surgeons to decrease mistakes and, really give us an opportunity to collaborate. I think that's a huge benefit of the VR platform. So we will soon be posting the link to the live feed. I'm going to stop sharing my screen. As we go into VR, we're going to be sharing it on the Zoom. We're also going to put a link in the chat where you can click into, where you'll get a higher resolution of the VR. And if you have any questions during the presentation and the surgical demonstration, please place them in the chat and I will help moderate our discussion. So any questions about Precision OS, VR in general, or if you have questions about whatever Dr. Getgood, Dr. Goel, and Marcelo are doing in the demonstration. So that's in the chat now. So if you click on the link, you can view their cast.
So Laurie and Al, I'm going to let you two sort of drive in. You can start with the knee anatomy and talk about, if you're a resident in PGY 1 to 5, or even a fellow who wants to be a proficient knee surgeon, and Al, you mentioned a pretty high failure rate. Maybe you can sort of talk through the anatomy, and then we'll get into the OR just shortly thereafter, you and Laurie and Marcello.
Cool. So I'm hoping you can actually see this. What we can do is actually just grab hold of the knee, and what we can see is here's a torn ACL. Okay, so basically you've got tibia, femur, patella sitting at the front, and we can see there, if we just look around, we can then see that the ACL is going from basically the anterior aspect of the tibia, and it's going up onto the lateral wall of the intercondylar notch, and it sits a little bit sort of posterior on the lateral wall of the intercondylar notch. Okay, and so what we're really wanting to do is trying to recreate that anatomy as best as possible. And we're going to do that through a view with the arthroscope. Okay, now obviously something we got to be very aware of course, are the meniscal structures. Okay, so we want to be in a position where we can at least try to preserve those, like I talked about in the presentation. And we're also going to look at the articular cartilage. So you've got the articular cartilage on the femur, as well as the articular cartilage on the tibia. And we're going to look at that during a diagnostic arthroscopy every time we do an ACL reconstruction.
Laurie, just to confirm, are you unmuted on Zoom?
I don't think she is.
I have to get Laurie to unmute here in just a minute.
I was unmuted, but now I am again. I should be.
Okay. And you're all good now, Laurie.
Oh, geez. Ooh, there we go. Okay.
Anything to add, Laurie, from what was commented by Al?
No, I think what's really neat about the VR in this situation is that you can actually look really close, and you can also imagine. So again, when you're scoping and operating, we always have muscles and soft tissue and skin and everything, and imagining all the angles. So arthroscopy is all about angles and anatomy. So when you have the model like this with the bone, you can really look at what your angles would be. So if you're thinking of like your tibial tunnel or your femoral tunnel, it's just a really nice way that you can pick up that leg and then look at where you're going. So it's a really nice way to confirm what you're doing in a real person when you have all that soft tissue in the way.
All right, great. Liana, any thoughts, any questions from the chat? If you just want to let us know, we could fire at them, or Al and Laurie can fire at them as needed.
Yeah, I will.
Okay. So we'll jump into the OR, and maybe Marcello, Al, and Laurie, you can talk through how you set the OR up. And Al, I think you showed a nice video of how you set it up. I'm just going to turn the voice off and I'll sort of stand back a little bit. But if you want to talk through that for us, that'd be really helpful.
Sure, I'll just move right over to the table.
All right.
Okay, so what we have, hang on 1 second, just move out of the way, but perfect. All right, so what we can see here, what's interesting about, you can see with the table, hang on a second, I'm just getting a little bit of an issue with my room boundary. That's better. Okay. And what we can see is the knee is basically set up at about 90 degrees of flexion, and that's always going to vary, you know, depending on setup. We have a lateral side post. You're going to have a foot roll down at the bottom. I tend to use 2 foot rolls, and the reason for that is I can grab the leg. Actually, I can actually set my foot. I can actually move the leg around, and then when I'm drilling one of my tunnels, I can put the leg right up into a deep flex position. And because the foot roll is sitting there, the leg will actually stay there. There are proprietary leg holders, for example, that you can use. So the setup really varies. But, you know, we want to basically be in a position where you can try and keep your hands as free as possible. That's particularly important if you don't have a lot of assistance. You know, and if we go back to that anatomy model that we talked about, we can actually pull the femur right out and the tibia right out of the leg, and we can have a look at the anatomy and then put it back in. So anytime that we've got the setup, we're going to come in, we're going to get the setup appropriate, and then we're going to do an examination under anesthetic. And an examination under anesthetic is absolutely key in terms of wanting to understand the laxity profile of the knee, in terms of varus valgus. We want to understand flexion. Do they hyperextend? These are sort of the things that we may start to consider, the type of graft or any augments or any other extra articular surgery or additional surgery that may be required. So the EUA is absolutely vital to do prior to getting going with the surgery.
All right.
Laurie, any other?
Continue to bring us. Yeah, go ahead, Serial.
Laurie, any other comments you want to add to that?
No, the only thing I'll add for setup, because Al talked about the exam really well, is, you know, arthroscopists get sore necks. So what's really neat is we can, you know, make sure we take our screens and put it so, like Al showed in his video, he had that screen straight ahead. So we can really move our screens around so we're not, you know, we're ergonomically appropriate. So we have a really great environment here for learning.
That's one, you know, that's a really good point. I find often with, you know, with my fellows, depending, you know, I'm a tall guy, I'm 6'3", and so I have a setup in a certain way. It may not work for absolutely everybody. You know, I find in the past where I've, you know, been working with someone who's a little bit shorter, they may not actually find the way I set things up that uncomfortable. So they've got to really understand that. And when they go into practice, workout works for them. It won't necessarily what I do work for them. Okay.
Okay. So why don't we all sort of help progress through to the next part here. So I really want to get to this next part here, which is, so this is asking us to pull the bone out of the body. We'll sort of move past that and get to the meat of the operation here. And I'm going to go here. So this is the knee assessment, which we already talked about. And maybe Laurie or Al, maybe just want to put us through a knee range of motion again, just to get us to the next stage. And then
absolutely. Okay. So and once you get the green light, we're good to go. I'm going to set it up at about 80 degrees, and then we'll be in a good position to get going with our scope.
And then I'm just gonna palpate here to get the appropriate position here. You can see I can actually, what I'm feeling there actually is when I palpate the skin or the virtual patient, that my controllers actually vibrate, giving me that tactile feedback on where I am in space there. So it's still evolving. I think it's going to get better over time, but it's certainly pretty exciting. So Al, why don't you go ahead with the scope and you can go into that lateral portal and tell us what you do for an assessment initially.
What's fun about this is that, you know, we can talk about portal position. We can, you know, we can, if you have someone in the OR with you, you know, this is a proprietary sort of setup in terms of how we do a particular ACL reconstruction with this particular industry system. So with this ConMed Infinity system. And so the portal's been designed specifically for that purpose. Now, if you're using a different system, you may want to use different portals, and there are pros and cons of different portal position. And that's a great opportunity to talk about that with your learners when you're doing that. Now I'm going to grab hold of the scope, and the scope normally is going to go into our, there we go, into the lateral portal. And now we get to actually see what's going on in here. If I can try and keep it in the right position. There we go. So I'm going to get it into there's our view of our, essentially of our intercondylar notch. Now I can actually grab hold of the light lead as well. Should be able to move it. Oh, all right. So I can actually move things around. I can change the light lead position. So as we know, it's a 30-degree scope. So, you know, Mark Miller's on the call. He always talks about wings horizontal. Okay, I always talk about, you know, keep your horizon horizontal, wings horizontal. You don't want to be moving your head. So you got to keep your head nice and still, but then you can move your eyes around. So I can move my eyes around the knee and I can look at the intercondylar notch, really nice view of the PCL coming down, come all the way through to the back. There's a lateral meniscus posterior root, go all the way through back here. You can actually see the posterior root of the medial meniscus. Okay, medial meniscus on that side. And, you know, we're focusing on ACL reconstruction here, but we could do a full diagnostic arthroscopy, which of course is what we would do in the normal scenario. Okay, so I'm going to pause it there. And then, okay.
So Al, if I'm trying to be an expert knee surgeon as a resident, what are the things I should be thinking about at this stage? I mean, you sort of dance around the knee because you've been doing, you know, 150 cases a year, but someone starting or someone who's never seen a knee before, how do they assess and improve on this skill?
Well, I think it's really,
I guess, a general question for Laurie yourself, and maybe even
so
Mark,
number one
on
is
the call.
it's repetition. It's getting involved, getting in the knee. And the first thing we're going to do is you're going to progress through a diagnostic arthroscopy. And once you get the diagnostic arthroscopy down pat, then we can then progress on to doing some more procedures. So maybe using the shaver to remove some tissue, doing some, you know, getting into maybe some meniscal resection if that's appropriate. And as you get better at actually being able to control the scope, you can then get into doing more advanced procedures, starting to drill some ACL tunnels. I tend to find actually the ACL tunnels are actually easier than a lot of the meniscus repair work. So as people get a little bit more advanced, then that's when they start to do a little bit more meniscal repair. And the reason for that, in the intercondylar notch, we've actually got quite a lot of space there. Whereas in either the medial or lateral compartments, there's less space. There's articular cartilage that can get damaged. So we've really got our skill set has got to be that little bit better to be able to cope in those tight spaces. Laurie, sure you've got lots of thoughts on that.
Yeah, I've got lots of thoughts always. So what I find with the residents that come with me is they tend to move the scope around. So understanding that 30-degree and what your whole field of view is. So I mean, the most common phrase I say in the OR when they're learning to scope is lead with your eyes. So like learners tend to move the whole scope around. So, and then of course you risk cartilage damage, right? I think I get, so like if you're moving the whole scope around, but really I can see a whole bunch, sorry, I fell out, by just moving my eyes. So I always talk about moving your eyes and seeing everything you can without even moving the scope. And that way you don't risk any cartilage damage. And I think this really allows you to practice that, because Al, you did it like totally automatic. As I would do is you use both hands and you move them in concert independently at the same time to see where you want to see, but that's not always so intuitive. So this really lets you practice that and lets you practice using your eyes without moving the scope. I think that's really key.
And then what you usually can do as well is also, just if I can just look at, you know, you can actually bring the leg out into more extent. You can put a little bit of valgus stress, and I can actually leave that position there. I can grab back hold of the scope, and now I can actually try and get into the medial compartment. Okay, so I can really have a good look around there. So, you know, it's pretty neat. And as Laurie says, you know, you're constantly trying to keep this position looking a reasonable position. And then, you know, I often just think of it as a bit of a dance. But there we go. So let's go back to 19. I'm sure, Danny, you probably want to progress on.
Yeah, why don't we shave, or if you want to go ahead and resect this off tissue. Actually, we're just going to move the length to 90 here.
Yeah, sure, I can do that.
Yeah.
So you can see that we get there we go.
There you go. And you could take the shaver and actually I'll just press continue here. There you go. Now you can get it.
So we do have one question from the chat. We have someone asking if we envision using synthesized images of actual patient pathology and their repair in the modules at some point. I think maybe more so than just with ACL reconstructions. Obviously, the images from the arthroscopy wouldn't be in here before we've done the repair.
Sorry, so Liana, the question is, it sounds like a technical question. The question would be,
yes,
can we add in pathology onto the scope image or onto the actual virtual patient?
I think onto the scope images. So if we know a patient has, you know, a posterior horn and an ACL, right, is that able to be projected?
Yeah, so what I would say is, because this is all, you know, this is actually three-dimensional anatomy, we would actually make the abnormality on the virtual patient. Because what Al is seeing is what's actually in the virtual space. So if there's this actual bone has an ACL tear, and so if somebody wanted to say, well, I want to see a meniscal tear we can do that. And actually, we actually have that coming out probably later this year, sort of a meniscal repair. So stay tuned for that.
Oh, great.
Yeah.
Very cool.
Not
So now what I can do is I can actually put this all into the knee. You can try to anyway.
So Al, I have a question for all the knee surgeons. I mean, you know, rotator cuff repair has a 2% failure rate. Kidding, of course, but
Yeah,
20%,
of course it does.
20% in the knee seems really high. So what's going on with a 20% failure rate?
Yeah, I mean, I think you've got to be very, you know, it's the devil's in the details. I mean, there's some publications really looking at very young athletes going back to high risk sports such as Australian rules football, maybe predominantly with a soft tissue graft with no lateral procedure. And, you know, some of those papers have really shown a high failure rate in that age group. And, you know, when we really drill down into our young active individuals, which, let's be honest, those are the patients that are probably mostly indicated for an ACL reconstruction, failure rates can be quite high. And so that's when we did the stability study. Laurie was a big part of that as well in Banff. And we were able to see that we could reduce our failure rates when a lateral tenodesis was added to a hamstring graft. Now, many people, if you're tuning in from the States, may actually be using a patella tendon as their routine graft. They certainly, the literature would suggest the failure rates are not as high with the patella tendon, in which case then there may not be those same issues. So it's very much age related, activity related, graft related, and surgical technique related. So lots of different, it's a multifactorial issue.
Yeah.
So I hope you saw that. I actually took that microfracture off and made a little mark
And,
so you can get rid of that.
And today in your practice, how many failed reconstructions are you seeing because of tunnel error placement? Actually, I'll continue that.
Yeah, sure, please. Thanks, yeah. Yeah, you know, it's certainly. I mean, there was a study from Pittsburgh a number of years ago which really looked at that, and certainly tunnel error or technical error is certainly the highest driver of revision, probably around about 60%. You know, that actually study hasn't really been repeated again in terms of actually whether or not that error rate is reducing. And to be honest, most of the revisions that I see often have a technical error associated with it. So there's no question there's a variability in how individual surgeons do surgery. We know that there's variability in where we place our grafts, how we teach where we place our grafts. And even I'm sure if I looked at 100 of my cases, we'd see some variability in terms of where I put it. So as technology evolves, we'll get to a point where we can be more accurate. And also when it comes to teaching, we can use tools like this to really try and hammer home where we should be trying to place these grafts and at least get people into a frame of mind of trying to reduce that variability.
And Al, at this point too, I don't know if we've gone too far in the program, but you can put your scope into that medial portal to double check where your all mark is too. So just like we might do, those of us who make that all mark with the scope in the lateral portal, you can still move your scope medially to take a look if you like your all mark.
Love that idea. There you go.
So, you know, theoretically, I mean, you know, as people continue to have access to this VR content, there's going to be a significant volume of data sort of demonstrating where people actually choose to put that femoral tunnel, which actually helps to standardize somewhat the care. If that's an error that you're still seeing, and you'll likely continue to see, Laurie and Al, in that regard.
So if I was being really critical of that, I would say it's a little bit too low. Okay.
For your portal, yeah.
Yeah, no, as in my mark. Okay, so for purpose of time, I'm just going to push on, but I would certainly, if that was real time, I tend to actually showed you that actually I use this two portals on the inside so I can actually do it in real time. But as Laurie said, by bringing my scope into the medial portal and I checked and I saw that, I would have gone back to the lateral portal, taken my microfracture roll and repositioned that microfracture roll mark, so it would have been a better position. So here now I'm going to bring the guide. Okay, so this is an offset guide that should come into there we go. Let's see if I can get this. There we go.
So just to clarify, Al, did I hear you correctly that you said you would use two scopes, or you just go back and forth medial and lateral?
Yeah, you go back and forth medial and lateral.
Okay. There you
There
go.
we go. And then we're going to advance this over, and then it locks it in place. I think that's it, isn't it?
Yeah.
Okay. And then I'm going to
So
let go of my.
I'll hit the continue button here, and
Perfect. And I can grab my drill. So I think what's really good about this system is that it really allows. Oh, hang on, this needs to be in deep flexion.
I'd have to put the drill down. Yeah.
Yeah, put the drill down. I've lost my deep flexion. Here we go. Let's go all the way up. Boom. And then let's just check this.
so why don't we restart it and just start at that step again, just to give you a better
Yeah,
chance.
please. Yeah.
The screen's just gonna go dark for a second, and I'll go back to step 4. There you go.
All right. There we go. So we were, okay, let's get our scope in.
And then you want to move it into hyperflexion here.
Yeah. So I'm going to take my light lead around, have a good look. Okay, we're going to go to hyperflexion. Boom.
There we go. You're pretty good at this, Al.
I've had a bit of practice. I don't know. It's, you know, it feels slightly. I mean, obviously, it feels slightly different than the real thing.
Yeah.
But in terms of the process is excellent, right? I need to continue that.
I'll hit continue. Yeah.
Yeah. Okay, so that's better now. So you can see now in a deep flex position, the guide is actually sitting right on the back wall, so right on the posterior condyle, and I'm sitting in a much better position to be able to advance this pin. So the pin's on now, and then it's a spade tip, and I'm going to bring it all the way through, and then it's going to come out the side. Perfect.
And how's that position for you, Al, on the thigh, with the pins coming out?
Yeah, looks good. Looks good. You certainly, if you were assessing it, you don't want it to be coming out too low, okay? Because that would be a concern that you'd be blowing out the back wall. And so, yeah, I'm totally fine with that position.
Okay,
This is
cool.
a good chance to take out your guide, this guy.
Yeah.
And then can you
Oh,
pull
actually,
the bone out then? Oh, do you have to?
Yeah.
Can you pull the bone out then, Danny, and show? Because then everyone
Yep.
can see where that guide's coming through the bone. It's just
Yeah,
really cool.
for
There
sure.
you go.
Yeah.
So cool. Like
Then
that.
just pick up your leg there. I like telling Al what to do. This is actually my favorite part. So pick up that. Yeah, pick up the bone there.
Reminds me
Yeah.
of a little. There we go. Look at
Al
that.
has PTSD from this. Okay. Yeah. So now you can actually
Hips
really
started to
see
twitch
this.
already.
Yeah, I know. So you can see it. Maybe
Wow.
it might be different than what you had imagined. Hey. So
So in terms of the position, so we can actually really see on the position there. Okay, actually doesn't look too bad. Okay, so pretty happy
your
with
entry
that.
point, yeah.
It's entry
Little
point.
posterior.
No, yeah.
That's
So
probably
a
your
little bit
angle
posterior
here, right?
Yeah. So the
Just
angle,
that
so
angle
certainly
you
would
went
want a
in.
deep flexion, as well as actually being able to drop the hand a little
Drop
bit, so you can actually bring out the exit point a little bit further up. Because certainly if you took a 10mm drill, for example, in here, you're slight risk of blowing out that back wall, but I think you'd be fine.
Yeah.
Okay, but for sure, I mean, it gives you definitely a great opportunity to have a look at that.
Yeah, it's really good feedback.
That's amazing. Okay.
Okay.
Yeah, I think that's the sort of real-time feedback for residents who have maybe never done an ACL or something that you can get by taking the bone out. It's been really, for me, when I've done these modules, that's what I have taken out for the most.
Just go
Being
ahead and
able
pull
to
the
see
wire back.
what kind of
actually helps.
mistakes
Oh, you
we're
just
making.
use.
Yeah, there you go.
Just till it vibrates.
That's good there. Yeah,
Yeah.
there you go.
Yeah, so that's sitting at about 30, just about 32. Okay. And then we're going to go on here, bring it in.
So a question for Liana while Al's drilling. So Liana, if you're doing your first ACL, where does that happen? Is that just in the OR as a resident?
No, I mean, you may see an ACL for the first time in the OR, but typically what we do is, our attendings have a lot of videos that we can watch. So you'll watch that, but that's really just like an arthroscopic video. So it's not necessarily looking at the whole picture, seeing the OR setup. So this is a great addition to the surgical educational toolbox seeing what the OR looks like. Obviously, you don't have all the towers and the, but this is a great way to get a feel for what that's like. And then you're able to do the module, so you know what the steps are, and you could do that, like what you would be doing were you the surgeon. And it gives you a little bit more perspective, in my opinion, of, even if you're not the one holding the drill or holding the camera, you can get a better idea of what's happening because you've actually had a rep or two with VR.
Yeah, for sure. That's a great point. So we sort of moved to the, I know we're getting short on time. We've got about another 3 or 4 minutes here, Al and Laurie and team. Let's talk about the
Laurie,
tibial tunnel.
Laurie, do you want to come in and do the tibia?
Yeah,
why are you coming out of the way?
I do have a question about the graft, however, when you pass it, and what do you do if you overpass it, and what's the bailout at that time? So why don't we do this part, and then we'll go to a Q&A on the Zoom call.
There we go. You gave me the hardest part. This was the part I said I didn't want Al to give me.
Why do you think I handed it off, Laura?
I know. I find this one just points down a little bit more than you think. There we go.
Yeah. There you got it.
There we go. All right, and then we're going to move this to there.
So Laurie, before you do that, just comment on that angle of approach. Like, I mean, I don't know where that goes. How do you tell people, or how do you teach people that angle of your tibial tunnel?
This angle down here?
Yeah,
so my big thing that I usually put this to 50 or 55, which I think this one's set at 55. So again, you want a long enough tunnel that your screw is adequate. So I tend to like at least a 30 screw. I know some people use a 25. I don't know, Al, what you're comfortable with, but just for fixation, the length of screw is important. And then I also think about bone. So again, if you go farther medially, you're going to get harder bone. You're going to get closer to that MCL and it's thicker cortex. So, if I have an older woman, perhaps with crappy bone, I might actually sneak that tunnel more medial than you might think I would normally do, just because I want to get that good bone quality. So there's different things I think about when I put that. Otherwise, if none of those things matter, I tend to put it just sort of in the middle between the tubercle and the medial border of the tibia. I don't know if you think anything different than that.
Yeah, no, it's absolutely perfect. And I think when you're using a hamstring graft, I mean, there's a number of different fixation options. So sometimes you might actually want to have a longer tunnel or a shorter tunnel. If we're using a patella tendon graft, you don't want to get what we call a tunnel mismatch, where the bone plug is sitting outside of the tibial tunnel, in which case you got to calculate the length of the tibial tunnel, and you can use some really nice sort of little rules. So there's an N+7, and more recently the N+10 rule. Another shout out to Mark Miller. Looking at basically the length of the intertendinous length, and you add 10 onto that, then you can set your angle of degrees to really try and get that length so that the bone plug sits right at the cortex.
All right. There we go. So you can see we've got our tibial line. Do you want me to straighten the knee, or are we going to move along? So you can straighten the knee here now and just see if, or we can, so I can capture that in there. I missed. I told you he gave me the hardest part. I think he tricked me on that one. There we go.
So there you go. So Laurie talked about, straightening the knee. There's a lot of people talk about being able to straighten the knee so you can look at the position of your tibial tunnel in relation to the intercondylar notch. I think you've got to be very careful when you do that, because sometimes the tibia can subluxate anteriorly, in which case then it'll give you a false sense of that you're actually sitting too anterior, and then the tendency is to push your pin back further.
Right.
So what's
and
nice
here you can do your
is
notchplasty if you want to.
Yeah, for sure.
Just joking, yeah. That was what Al did when
nice
he was our fellow.
Oh, multiple times.
Yeah.
Is that you can see the meniscal anatomy, and we can use the meniscal anatomy, particularly the anterior horn of the lateral meniscus, as a guide to our tibial footprint position. So lots of really good anatomical landmarks we can utilize.
Yeah.
Okay, sure. we've got a few more minutes. I just want to skip forward to the graft if we can.
Okay, for sure.
So I'm going to pull this out, but so if you pass the graft and something goes wrong with the graft, what's your bailout at that time? What can you do in that scenario?
So with most
if you've pulled too much, or if you haven't pulled enough, what are the options there?
So for most variable loop buttons, there aren't too many options, because once you shorten that loop, you can't do anything with it. This button is actually one of the special ones where it has this little blue tab here. This actually is a little rescue suture that lets you lengthen the button again. So if you screw up pulling up the graft, and you want to just start over again with shortening your variable loop, if you pull on this tab right here, this blue one you see, that will open up the loop and let you pull the graft back. So if you can grab it there, get those out of the way. Both probably can't do it at the same time.
The interesting thing, Danny, as well, is that
there you go.
you
Yeah,
very,
there you go. That's it.
Yeah.
you
So
very
if you pull on
nicely
that-
moved on to you nicely moved on to the next step when I was drilling the femoral tunnel, because I actually blew out the lateral cortex.
Yeah.
And
Oh,
that
Did you
what
see it
happens
there?
then? Well, no, because we moved on the
Oh.
step and he
Oh, we
actually
moved,
he
yeah.
changed it
Yeah.
up. But what happens if you've blown out the lateral cortex? You then can no longer have this button actually sitting on the cortex because the tunnel is too big. So there are different options. We can use a larger button, so you can add a button onto a button. You can just take the loop out and then fix it with either a staple or a screw post. I mean, ultimately, ACL surgery is relatively straightforward if everything goes well. When things start to go wrong, you need an awful lot of techniques and and a lot of options to be able to bail yourself out of problems, and that's particularly the case when you're teaching. Because unfortunately, when you're teaching, things sometimes go wrong, and you have to be able to work out ways of managing that. And different grafts have different problems. Posterior cortex blowout, for example, is a problem, particularly if you're using an interference screw fixation. If you're using suspension fixation, it's not as big a problem. So it's knowing the pearls and pitfalls and of the different constructs that you're using, and then being able to have a number of tools in your toolbox to be able to deal with it.
So team, we could probably spend another hour in here, I'm sure, but we're short on time. Let's go back to the Zoom call. That was really fantastic. Thank you all. And I'll end and we'll go back on Zoom, turn our cameras on and see if there's any more questions.
Okay.
But thank you both.
All right, thanks.
Anyone has any questions about either the module we just watched, our excellent faculty work through, or any general questions about VR and education, please, you can either put them in the chat and I'd be happy to we can talk through them. Thank you all for going through that. I think if you haven't seen a lot of VR, it's very cool to watch people go through the module and see all the little tips and tricks. You guys are obviously experts on knee surgery. So it's very interesting to see how you're using it versus how perhaps I was using it, or one of our junior residents is using VR for both a technical brush up or a educational tool. Have you used, Dr. Getgood or Dr. Hiemstra, have you used this with your residents or fellows?
Yeah, I mean, we certainly haven't brought it into our curriculum as standard within our residency program. I have my own headset, and so I've had some of our fellows use it. But it's getting traction, and hopefully within the residency program it will continue to get some traction at Western. But I think there's a great opportunity there for people to utilize it, particularly before a case, to really understand the steps in the process. It's difficult to sometimes get that information across, and if they have limited amount of time in the OR with you, if they can come in with an understanding of how the case flows and what they can do, that hopefully speeds them up so they can get to a point where they can actually do some more of the surgery. See, Mark Miller's got a question there.
Yeah, I'd like to be able to see if we could figure out a way to watch the resident do this rather than just have them dance around, with their headset, and actually see what they're seeing. I'd like to be able to teach them and watch them do this and see myself what they're doing. Is there a possibility to do that?
Yeah, it's an excellent question, Dr. Miller. So the view you saw was actually through my headset, which we actually recorded. So if you have a resident going through this, you'll be able to see where she or he is actually looking at all times. So I don't know if you do this, Al, but if you do use the C-arm still for your ACLs in London. So
no,
you don't. Okay. So, some of the surgeons that use imaging for cases, you can actually see how long they're looking at the image for. And so you can dissect that down to say this is prolonged. It's, it sort of signifies a sort of delay in thinking and decision making. But that's 100% we can do today.
Yeah, the whole thing seems a little bit stilted and, like first generation silent film thing. We have a long way to go. It's tremendous technology. I'd love to see this advance, and I'm happy to be involved. I really want this to, I think this is the future, but it's still a little stilted and awkward,
Yeah,
No,
there's no question. Go ahead, Al.
Sorry, Mark, I think you bring up a great point, and I think it'd be great for you to give it a go and get a headset on and join us in a VR room, and you'd really get an understanding of what you can do. It's not the same as real surgery, of course, but there are lots of things that you can do with that, and the discussion that you can potentially have, and take a resident to the next level in terms of their thinking and being in an environment that maybe, I don't know if it's the same for you, but in my OR, it's very difficult sometimes to spend the time to go through the individual steps in a really slow, methodical manner, because we're looking at the clock. We've got things where the cases have got to go, the patient's under anesthetic. Here, you can really take your time and you can go through lots and lots of questions. You can answer a lot of their questions in real time. Is it going to completely overtake from maybe cadaveric training, for example, or real-time surgery? Of course not. But it's a big help. It's a big step forward.
No, I agree. I'm trying. I got my own set. I'm trying to figure it out, but I'm really stupid about this.
We'll have to join. We'll get on.
Dr. Getgood, that's what I wanted to ask. What advantages does the surgery training has in VR compared to the traditional book learning? What do you think?
Well, I think my understanding is that there has been some really nice research that's showing that people, when they actually do a procedure, they learn much more quickly than just reading it. So, traditionally, if you're being shown a new implant or a new technique, your rep may come in and show you a PDF, and you're reading a PDF. The ability to pop a headset on and do the procedure, I can see there's other modules, for example, with other prostheses, for example, a revision knee replacement. There are multiple steps to doing a revision knee replacement. To read on a PDF is so much more different than actually doing it and taking the block, putting the block on the knee, taking the little widget, putting the widget into the block. There's lots of little things, and I think that's where it really is very advantageous. So that's where then the experienced surgeon can actually benefit from it, not just the learner. Okay, so that there's a whole range of learning opportunities for those of us that still, and at the end of the day, surgery is one of those things that you're going to keep learning until you retire.
I think the other thing you can learn, I was doing an ACL earlier today and I screwed up the tibial tunnel. It was too short, and I have the scope in and the screw came right into the knee when I put the screw in. So you can also make mistakes intentionally or not, depending if you're playing around or you're teaching a resident. And then you have that real-time feedback, I think, is really key. Like we showed, pulling the bone out and seeing where Al's tunnel went, because your tunnel looked perfect from inside the knee, right? The starting point was perfect or pretty close, but then you can see where things can go wrong by pulling it out. So I think that real-time feedback is really important, especially when you make mistakes, because you learn way more from mistakes than you do from doing things perfect, for sure.
Definitely. We have one question in the chat asking about haptics. Can you talk a little bit about what kind of feedback you are getting in this module? I know we talked a little bit about touching the knee and you're getting a little vibration, but maybe you guys can talk about that a bit.
Yeah, you get a. Go ahead, Laurie, please go ahead.
Oh, yeah. So when we're using that drill, you can actually feel it vibrate. You can hear it also. I don't know if you could hear it through our things, but you can hear the drill go and you can feel it vibrate, and they feel different. When you pulled back that guide wire like Al was doing, when that tip hit thing, it was just a very subtle vibration. When you're using a drill, it's a bigger vibration. So there's definitely some scale on those haptics, and that they're palpable as well as hearing, audible.
Yeah, what you don't get is you don't get the feeling of the scope sitting in the portals, and so you actually have to use your hands and keep your hands a little bit more still than maybe you would do. It's a little bit more active than a scope, where a scope can actually sometimes be a little bit more passive. And again, what you do get is you get a very clear sense of when you move your hands, how that affects your vision. And I think with that sort of where you have a probe in the knee and you're actually moving your hands and you're dancing around, that's where I think you can get a lot of feedback for a learner to understand that process.
Awesome. Well, thank you everyone for coming. Al, you were a wonderful visiting professor for our first VR Professor series. Everyone who's joined us online, thank you very much. Precision OS, all the education and support people, and Danny, of course, for bringing us along. Thank you. Marcello and Liana, thank you for helping us along here. So with that, if you have any other questions, you can pass them along through email or whatever, but we hope you will join us for further episodes of this series. And everyone have a really great night.
Thanks, everybody.
Good night, everyone.
Have a great night.
Thanks so much, everyone.
Everyone.
Thank
Bye-bye.
you, everyone.
Good night.